the kidney is a very important organ for degradation of many hormones. Actually, most of the hormones are degraded in the kidney. Some metabolic functions, also like gluconeogenesis, and when this function is disturbed, then you get a lot of manifestations of the dysfunction, like fluid retention, hypernatremia, edema, manifestations of congestive heart failure, hypertension, hyperkalemia, or sometimes hypokalemia, metabolic acidosis, osteodystrophy, hypermagnesemia because of lack of excretion of magnesium. Sometimes hypomagnesemia also can occur. Hyperphosphatemia and very rarely hypophosphatemia, causing osteodystrophy. And there is problem with the excretion of nitrogen, which is an essential part of the content of protein and amino acid diet, and this would cause a lot of manifestation like anorexia, nausea, itching, and inflammation of the serous sacs like pericarditis, and it can cause also problem with the nerves, so polyneuropathy can occur, and even in the brain itself, causing encephalopathy, and it can cause thrombocytopenia and bleeding. So a lot of manifestation can result from lack of excretion or deficient excretion of nitrogenous end product. When the endocrine function is disturbed, then you get osteomalacia, osteodystrophy, anemia, and hypertension. So let us see a common case. This is a case that we see a lot in our department. This is a 65-year-old gentleman who is seen by his family practitioner for a routine health evaluation. He has a history of hypertension, diabetes mellitus type 2, and gout. So these are triads that are very bad triads. And this has been there for more than 10 years. And the patient coming reports fatigue, decreased appetite, lower extremity edema for the last few months. So if you see these complaints or these symptoms, it wouldn't directly indicate renal problem, but the treating physician might have different opinion. The patient's current medications included atenolol and hypertensive 50 milligram a day, hydrochlorothiazide, which is a thiazide diuretic, 25 milligram a day, metformin for diabetes, which is 1,000 milligram per twice daily, so 2,000 a day, which is a lot for this patient with renal disease. And the patient is actually a smoker, at least 1 pack a day for many years of cigarettes. On examination, the patient is obese, 90 kilogram, and his pulse is normal, 78, regular. Blood pressure is a bit high, 178 over 96 millimeter mercury. And facial examination shows periorbital edema, and fundus examination reveals arteriovenous nicking and scattered cotton wool exudates. So these are manifestations of chronic hypertension with some changes in the retina. Neck examination showed that the jugular venous pressure is 18 centimeter, and both lungs are clear to auscultation, and heart sounds are regular. But there are no abnormality, there are no abdominal masses, but there is lower extremities edema in the lower extremities with diminished peripheral pulsations. So there is atherosclerosis. But this manifestation, although does not directly indicate the presence of renal problem because they are away from the anatomical site of the kidney, but the family practitioner wonders if this gentleman has renal disease. So this information, do you know how he based this information on? Why he thought of renal disease? Anyone can answer this question?
Maybe because of the edema, and he has a risk factor of diabetes and hypertension.
Excellent answer. Actually, the patient has got many risk factors. Diabetes for a long time, probably uncontrolled. Hypertension, probably uncontrolled. And he's a bit middle-aged. And also the symptoms might, to some extent, point to some problems in the kidney. Do you know what are these symptoms? Fatigue, decreased appetite, and swelling of the lower limbs. These are symptoms that, although very non-specific, but should direct us toward renal disease. Okay? And in examination, the presence of periorbital edema usually indicates some problem in the kidney. Unfortunately, there is no mentioning about pallor and complexion of the patient, but pallor is also very important. And the bad effect of hypertension and diabetes on the retina indicate that they might have bad effect on the kidneys as well. And the high jugular venous pressure, besides the edema, indicate that this patient has got some volume overload. So I think, in my opinion, the family practitioner is very right to consider renal disease. So, how this patient's renal function is measured and his kidney status assessed. So, this is a question,
By an investigation.
right? So, we need to know which investigation actually. If this is the structure of the nephron, you think that filtration occurs here. I believe that. Then, along all these tubules, reabsorption and secretion occurs to just modulate the urine. And here in the glomeruli, this is a cartoon of the ultrastructure of the glomeruli, there is some selective filtration and sieving of important things through the kidney to make urine. And this is the how the podocytes support the outer surface of the glomerular basement membrane with the food processes, and the filtration occur from inside the capillary lumen to the outside there. So I would think that small molecules can filter here, and larger molecules and negatively charged molecules are kept inside, like blood and albumin. So if we have an overview of what goes wrong with the kidney, so we can think of problem infiltration, which is the main function of the kidney, and this also carries with it sometimes problem with the sieving properties. So sieving problem means excretion or filtration of very small molecules and keeping negatively charged and large molecules that are very essential for life. So if the sieving is not good, then blood can be filtered through the glomeruli, or at least protein or proteinaceous material can be filtered. This can cause depletion of the protein from the patient. There can be also some concentration and dilution problems, so the patient might not excrete the urine as it should be, and this can result in some problem in volume regulation, either hypervolemia or hypovolemia. And also there might be some ion and mineral problem due to problem in their adjustment, either excretion, filtration, or reabsorption. And there might be some problem with the endocrine and metabolic functions. And at last, there can be problem with the excretion of the product of the kidney to outside. So uh, investigation should focus on these problems. But if you consider renal failure or chronic kidney disease or acute kidney disease or acute kidney injury, the compromised function usually that we are look for is the filtration function. So this is the most important function that we focus on investigation to diagnose renal failure. We usually look into the filtration of the kidney. So to identify and define the presence of renal problem, we assess filtration by serum creatinine and blood urea nitrogen or urea. Sometimes you use uric acid also, but this is not very accurate as the above two. So creatinine and urea are very important markers of filtration, and we will see that in a minute. But which one do you choose, creatinine or urea? Each one has its own advantages and disadvantages. None of them is 100% accurate, but are reasonably valid for assessment of filtration. Reasonably valid. So these are markers of filtration. And we can measure the filtration rate. We call it the glomerular filtration rate, or the GFR, through measuring creatinine in blood or sometimes in blood and urine. The second problem we assess is assessment of the sieving function, dilution, and the concentration function of the kidney. We do that by examining the urine by urine chemistry, urine physical appearance, and urine microscopy. So if the urine contains the blood that's coming from the glomeruli, then it is a problem of sieving the blood. If the urine contains the protein, then it is a problem of sieving to prevent protein. Then some tests are very important for assessment of ion and the mineral problems. So we measure blood and urine electrolytes and acid base, and we measure blood and urine minerals. Electrolytes like sodium, potassium bicarbonate, and acid bases bicarbonate, pH, and PCO2. These are the important acid bases that are measured. Do you hear me?
Yes,
Oh, right.
Yes.
Because last time I was lost when I was presenting, and I didn't know that I was out of presentation. How do we assess the endocrine and the metabolic function? We do serum calcium, serum phosphorus, serum magnesium, serum parathyroid hormone, blood glucose, bone metabolites sometimes, and we usually evaluate hemoglobin and evaluate anemia, and sometimes we measure other hormones and the growth factors. But we have to choose which test because there are a lot of tests. So all of these tests are for identification uh, and define the presence of renal problem. So Uh, the most important investigation that we usually do it serially, is creatinine, sometimes urea, and uric acid. Creatinine may be a little bit more accurate than urea because it is not changed that much by changing the body water and intake of protein. Occasionally, some hospitals can also assess other non-nitrogenous compounds. However, these uh, parameters or these variables can also change with exogenous intake and the endogenous rate of production, as well as extrarenal excretion. So their validity is not that strong, although they still valid. So what is glomerular filtration rate? Glomerular filtration rate is the average filtration of each single nephron. And to make it more valid, we standardize it by expression per 1.73 square meter of surface area. And this is how we calculate the surface area of the body. And the normal GFR is around 130 or 120 in men and women respectively. So this is the normal GFR. And we use creatinine usually to make an estimation of the GFR because creatinine reflects the GFR as you see in this curve. However, the relation between creatinine and the GFR measured is not a linear one. As you see, it is like a J-shaped curve. These are some causes that makes the interpretation of urea and creatinine a little bit problematic. Some causes can reduce the urea to creatinine ratio, like low protein diet, malnutrition, syndrome of inappropriate antidiuretic hormone secretion, in pregnancy, in severe liver dysfunction, and in rhabdomyolysis. So all of these things can cause urea to be decreased or creatinine to be increased. So the ratio between them is not as expected. Usually, if you divide urea by creatinine, you get level between 20 and 35 or by most 40. So if the urea creatinine ratio is high, this means that there might be uh, volume concentration, or volume deficiency. We call it pre-renal problem. And the reverse, if the urea to creatinine ratio is very low, like less than 20, less than 15, then this might be due to one of these causes. There are some formula that estimate the GFR from creatinine. If you look at this formula, here it contains this called Cockcroft-Gault formula. It is enlarged here. If you look at this formula, it contains only as a measured creatinine, and all of the other are either physical measurements from the patients or some fixed numbers. So creatinine clearance, which is related to the GFR very much, equal 140 minus age times weight divided by a constant, another constant. Here is 140 is a constant, 72 is another constant, times plasma creatinine in milligram per deciliter. So if you apply that, you can estimate the creatinine clearance, and then GFR, and that's GFR. But in females, you time that by 0.585 to compensate for their lower muscle mass. Right? So try to memorize uh, this equation. But there are also some other equations. One of them called MDRD, study equation. And here it contains age. The first one, there was age, yes, and weight. Here is no weight. So it contains age and also race. Because if black, you time it by 1.210. And also gender. So here, age only, no effect of weight in this equation. Another standardized equation is here. This is MDRD. MDRD is a research called modified disease, renal disease. And in your mobile, there is an app, Android and whatever, that can also calculate the GFR in many other equations. So you can use them. Now we go to urine. The first thing that you meet when you see patients in your clinical training is the urine bag. If the patient comes to the clinic, you ask him about the urine and urine color, but you can have a tube that you collect some urine in it and you can see it by yourself. And sometimes you can see change in the urine color, like green urine here, with many causes like dyes and drugs, and occasionally some infection that can cause green urine. And here's another color of the urine, which is orange or reddish orange. And sometimes there is dark brown or Coca-Cola like urine, like cases of hemoglobinuria or myoglobinuria, and cases of porphyria, some bile pigments. Occasionally, some food and drugs can cause this brownish or dark brown urine. This is violet urine or purple urine that can occur by some toxin, some bacteria. And the most important test, which is achievement of the 20th century, is the urine dipstick that costs only 30 cents or something like 2-3 pounds per test and takes 3 minutes only or even 2 minutes, and can tell you a lot about the kidney. Here is one that contains many reagents, and it looks like a portable or mobile laboratory in your pocket that you can use, and you can test something up to 12 or even more variables in the urine, like protein, blood or hemoglobin, bilirubin, urobilinogen, glucose, ketones, specific gravity, nitrites, and whatever. There are a lot of things. One of the important component that you look for in urine is the protein, because you use this proteinuria for classification of chronic kidney disease. A1, A2, A3, every category of proteinuria carries a specific risk for the patient, risk for progression and risk for cardiovascular problem. So A1 is normal or mild increased proteinuria that is less than 30 milligram per gram creatinine in urine. A2 is moderately increased, which is synonym to microalbuminuria, and A3 is severe or severely increased, that is macroalbuminuria. And the green color here means low or no risk. Yellow color means mild risk. Orange means moderate risk, and red is severe or very high risk of progression. And you combine this category of proteinuria with a degree of impairment of the GFR to get the amount of risk for each patient. And we measure proteinuria by different mechanisms. The most important, but might be not very quantitative, is the dipstick. And it tells you how much, but not very sensitive, amount of protein, like negative trace, +1, +2, +3, +4 sometimes. But it can be false positive with high urinary specific gravity, or if the urine is very alkaline, or sometimes in the presence of urinary tract infection and the use of antiseptics in the collecting vessel. This dipstick is sensitive to albumin. We call it semi-quantitative because when you see it's +1, you mean that it is more than 30 but less than 100. +2 is more than 100 but less than 3 or 400. +3 is sometimes more than 300 but less than 500, and 4+ is more than 500 or even 1,000. This is milligram per deciliter. So these are semi-quantitative methods. But there are other chemical methods for measuring protein in urine. All are qualitative, like the precipitation technique, like the sulfuric acid technique, measured by turbidometry, and others. But the most easy one is just heating. You can get a urine in the test tube and expose it to some heat. When the temperature increases above 50 or 60, the urine comes into cloudness or precipitation in the bottle, saying that it is protein. If you add something like glacial acetic acid, the precipitation or flocculation even increase more. But if it is other salts, it might be dissolved by the glacial acetic acid. Quantitative method is measurement of protein in urine either against time, like 24 urine protein, or finding a relation between urine and urine protein and urine creatinine. So finding a relation between urine protein and urine creatinine, try to fix the effect of dilution and the concentration of urine by dividing urine protein on urine creatinine. But the timed collection is more accurate and famous. We can collect urine in 24 hours or any time collection. Actually, the most preferred is the overnight urinary protein collection. But we measure urinary, either urinary protein itself or urinary albumin specifically, and get a correction by dividing it on urinary creatinine, either in getting in gram per gram or milligram per gram or even milligram per millimole. Actually, any random urine sample can work, but we prefer the first or second morning sample just to alleviate the effect of what we call orthostatic proteinuria. This is proteinuria that comes with exercise and standing for a long time, and it is improved with lying down. And this is a benign condition. So we get the first or second void in the morning just to avoid the effect of such orthostatic proteinuria or exercise induced proteinuria. So normal urinary protein over creatinine ratio is less than 0.2 gram per, or if you want to say milligram per gram, then it's less than 200. And normal urinary albumin over creatinine ratio is less than 0.05 gram per gram or less than 50 milligram per gram. So there is some causes of false positive and false negative proteinuria, especially by diabetic, like positive, like with alkaline urine and very concentrated urine, and if the stick test is left in the urine for a long time. False negative when the protein excretion is not albumin but other low molecular weight protein like Ben Jones proteinuria, or when the urine is very diluted. If the patient drinks a lot and the urine becomes diluted, then the proteinuria might not be covered in urine easily. Here are some causes of false negative and false positive tests for the dipstick: specific gravity, pH, hemoglobin, glucose, albumin, leukocyte esterase, nitrites, and ketones. The most important part of urine analysis also is urine microscopy. So examination of the urine under microscope is a little bit more difficult than the dipstick, but the results are worthwhile. So we look at cells, casts, crystals, infecting organisms, and some others like spermatozoa, mucal threads, cylindruria, fibers, starch, hair, myelin bodies, sometimes even necrotic tissue. So there are a lot to find by microscopy. So important sediments that are related to disease like lipiduria, lipid in urine, and marked cylindruria in nephrotic syndrome. But in nephritic syndrome, there is a lot of hematuria, and most importantly is the erythrocyte or hemoglobin casts. You find the casts of blood. In acute tuberous necrosis, you find necrotic tissue in urine or damaged renal tubular cells. Sometimes you find epithelial or muddy brown granular casts. In urinary tract infection, you find leukocytes in urine and bacteria, and sometimes if there is pyelonephritis, you find leukocyte casts. And in polyoma or BK viral infection, you find what is called the decoy cell. It's not that easy. This is usually in transplantation. This is a microphotograph of monomorphic hematuria. These RBCs are all look like, and it looks like an intact RBCs, as you can see here. So when it is like that, you can consider that the hematuria is not glomerular hematuria, but coming from the uroepithelium. But here you can find some glomerular and some non-glomerular hematuria. Like here, the arrows indicate the so-called crenated RBCs, like here, there, and this one. And here are the dysmorphic RBCs that is characteristic of glomerular hematuria. These are acanthocytes with blebs in the RBCs in urine, in the cell membrane with irregularity, and blebs of different sizes and shapes. So these are the dysmorphic RBCs that are characteristics of glomerular. Another important characteristic of glomeruloproteinuria is the presence of hemoglobin or RBCs casts here. As you see here, this is a cast that is apparent in urine with hemoglobin inside or RBCs inside. So in glomerulonephritis, urine analysis is very helpful. Smoky urine, oliguria, hematuria, proteinuria, dysmorphic RBCs, and RBCs casts. So when you see that, you go and assess the renal function and you do routine lab. And you do a surveillance of infection and systemic vasculitis because these are common causes of glomerulonephritis. And don't forget to do autoantibodies for autoimmune disease like anti-nuclear antibodies, anti-double-strand DNA, anti-neutrophil cytoplasma antibodies, and anti-streptolysin autotetra, etc. And sometimes even you need to do plasma electrophoresis to diagnose plasma cell dyscrasia. All of these are common causes of glomerulonephritis. In CKD, your approach mainly is for assessment of the activity of the underlying disease, which is the cause of such problem. Examples are to measure blood glucose in cases of diabetic nephropathy. You measure uric acid in cases of urate nephropathy. And you do tests for systemic lupus erythematosus and the vasculitis, and the titer of the serology there to know whether the disease are active or become inactive. So you do something like erythrocyte sedimentation rate, anti-double-strand DNA, other autoantibodies, anti-neutrophil cytoplasma antibodies. And you do protein electrophoresis to rule out paraproteinemia and to see if the disease is in remission or exacerbation. One important task of investigation in patients with chronic kidney disease is assessment of progression of renal disease. So you have to measure serial measurements of creatinine or glomerular filtration rate if possible. And you do serial urine analysis. And also in chronic kidney disease, it is important to assess the impact of renal disease on the patient because sometimes the impact can be devastating and can be even fatal. So you do serial hemoglobin, serial electrolytes and acid base, and serial mineral level. The most important electrolyte and acid base variables that you measure are serum sodium, serum potassium, serum bicarbonate, serum chloride, and also you do mineral like calcium, phosphorus, and magnesium. This is anti-neutrophil cytoplasmic antibody, which is characteristic of vasculitis, especially small vessel vasculitis. You do it usually in the serum and either by ELISA or by the fluorescent microscopy, and this is by some scanning microscopy. One important task when you deal with a case of chronic kidney disease is to distinguish between acute and the chronic kidney disease. This can be done by history taking and examination. So if the history denotes long-term problem with the kidney, then it is chronic. If just an incident problem and the patient was free a few weeks ago, then it can be acute. And look for the chronic metabolic bone disease with high parathyroid hormone in chronic but not in acute. Anemia is commoner in chronic, but it can occur sometimes in acute when there is hemolysis or bleeding. And ultrasound can help you showing bilateral small size echogenic kidney. If it is so, then it's chronic, but it's not very specific or very accurate. And you compare the clinical and the laboratory data to see if the clinical data are far more than the laboratory data. This with acute is the laboratory data is very highly advanced than the clinical data, then it can be chronic. But all of these are non-specific. So you just add things together. You sum up clinical by laboratory and imaging and comparison to get a good conclusion on which type of kidney disease, acute versus chronic. And in every case with chronic kidney disease, usually look for the etiology of the chronic renal disease. And you have to integrate the clinical laboratory and imaging finding to get a conclusion about the etiology, whether it's diabetes, hypertension, or autoimmune disease or whatever. So you have to look for the etiology. You have to deal with it if you can to prevent progression of kidney disease. Sometimes you can induce amelioration. But at last, a very important tool for investigation is not laboratory, it's renal biopsy. And when you get renal biopsy, you send it to the lab, but not to the chemical lab, but to the pathology lab to get a good view on what is wrong with the kidney and what is the type of pathology occurring there. So in this lecture, I tried to cover some of the important investigations that you have to look at when you go to the word round or when you go to the clinical training. You have look at the patient file, you look patient files, you look at the materials, and you look at the investigation results to get a good clue on what is wrong with the patient. Okay, so you will have, inshallah, another lecture, not with me, with imaging and the importance of imaging of the kidney. Right, so I'm ready if there is any question.
Doctor, can you upload the PDF to the Teams?
Right, I will.
Okay,
I will
thank
do
you.
that. Any other request? Any question in the lecture? Any comment?
Thank you, Doctor.
Any criticism? Did you like it?
Yes, sir.
Yes, Doctor. Thank you so much. It was nice.
Right. Okay. So no questions. I'm waiting. We still have 5 minutes.
Doctor,
Yes.
I would like to ask,
Right. You can.
for the cases earlier that you gave, it mentioned that he had arteriovenous leaking.
Yeah.
What does that mean?
Right. I don't want to go into the details of that because you will study this when you go to the ophthalmology, inshallah, in semester 9, I think, or semester 10. So it's just a mark of the artery on the vein. The artery is becomes thickened and sclerosed, so it causes a mark on the vein, obstructing the venous flow. Right? But don't bother yourself with that. Just know that there is some changes in the vessels that can be seen in the retina.
Oh, okay. Okay, thank you,
Right?
doctor. All right.
So about the case, what do you think? Was the GP or family doctor right in thinking of renal disease? So if you would like to investigate this case, what would you do?
Do some serum creatinine test.
Right? Right. So serum creatinine was 4, actually, 4.5 milligram per deciliter. What else would you like to do?
Urine
Yeah,
test.
right. Urine. His urine showed proteinuria +2, and the protein creatinine ratio was 1.5 gram per gram. So it is a bit moderate proteinuria, more moderate to severe proteinuria, but not nephrotic range. So creatinine is 4.5, and urine showed proteinuria and some granular casts, but no much hematuria, no RBC casts. What else would you order? Just ask me. Hmm? I would do uric acid.
Oh yeah.
His uric acid actually was 11 milligram per deciliter, which is a lot high. And this can be one of the progressors of kidney disease. So if you treat hyperuricemia, you might blunt the progression of the kidney disease, or even you can have some amelioration. What else would you have? Would you ask for? I would do hemoglobin and CBC to see the blood. What do you expect about the hemoglobin in this case? High or low or normal?
Low.
Maybe.
Yeah, actually it was low. His hemoglobin was 8.5 gram per deciliter, which is a lot low. And the anemia might be responsible for his fatigue. What else would you ask? One serious problem you have to look for.
High blood pressure.
But this is not investigation. The blood pressure is already measured, and it is 176 over 97, I think, or over 96. So it's already measured. But investigation wise, the lab, what else would you do?
GFR.
Yeah, GFR is related to creatinine. His creatinine is 4.5. Can you calculate the GFR by the Gold-Cockcroft method? Remember, he is 65 year. Huh? Do you remember the equation?
No, doctor.
140 take away age. So 140 take away 65 is that 75? Hmm? Let us say it's 72. So 140 take away 68 is 72. If he is 68, 72 times the body weight, which is 90, divided by 72 times serum creatinine, plasma creatinine. So 90 up and the plasma creatinine down. Plasma creatinine is 4.5. So 90 divided by 4.5 is 20, isn't it? 90 divided by 45 is 20, isn't it? So his GFR is 20. So this how to use the Gold-Cockcroft method or equation to calculate the GFR. It's not very accurate, but it can do. It's helpful. Or you go to your mobile, you open your Android, you search for the app, and you get an app for calculation or calculate the estimated GFR, and you find many apps actually, and you calculate the GFR by that. What else would you do? Hello? Are you still there?
Calcium.
Yes. Most importantly, I do potassium
Oh.
because it's quite tricky. A patient with hypertension and diabetes might have hyperkalemia if he's got renal failure, especially if he is on potassium-sparing diuretics or ACE inhibitors. Fortunately, this patient is not on ACE inhibitor or ARBs. You know what ACE inhibitor is?
What?
ACE inhibitor,
Oh yeah.
ARBs, angiotensin receptor blocker. These drugs cause hyperkalemia, especially if they are combined with renal problem, diabetes mellitus, and especially with spironolactone, the potassium-sparing diuretics. But this patient was on thiazide diuretic, which does not cause hyperkalemia. Hyperkalemia can be fatal. A serum potassium above 7 is very hazardous. 7.5 cause cardiac toxicity, and more than that can cause cardiac arrest. It's one of the catastrophic cause of death in patients with chronic kidney disease, especially after overindulging in diet containing a lot of potassium, like dates, apricots, nuts, potatoes, things like that. Would you like to ask for serum sodium?
Yeah.
Serum sodium actually changes a lot with the state of hydration or water in the patient. If he drinks a lot and he doesn't secrete the water load, then serum sodium would be low. He would have hyponatremia, and this can cause headache and fatigue, lassitude, and even mental obtundation or decreased consciousness. But if he's thirsty and wouldn't drink, water is not available, and the kidney cannot dilute, it cannot concentrate the urine, then he would have hypernatremia with also a lot of CNS side effects. Calcium and phosphorus is important because many of these patients might have bone disease. So you do calcium, phosphorus. Many of them would have hyperphosphatemia, and we've got to advise him about the diet if he's got hyperphosphatemia. And we usually give the patient a phosphorus chelating agent or a phosphate binding drugs like antacids or calcium, oral calcium. And we look also at the parathyroid hormone because hyperparathyroidism can cause severe bone disease that can cause a lot of morbidity and sometimes even can lead to mortality. What else would you do? Would you do blood glucose? Actually, it's very important because this patient has got renal disease, advanced kidney disease, and he is on anti-diabetic drug oral, which is usually excreted through the kidney. And if the kidney is not functioning well, this anti-diabetic drug will be retained and can cause problem with diabetes. Especially, this patient is on metformin. It's not a strong anti-diabetic drug, but it can cause metabolic acidosis, lactic acidosis in patients with renal failure. So acid base should be measured, actually. And this patient have actually metabolic acidosis. His bicarbonate is 11, and his pH is low. So he needed bicarbonate therapy. All right. So I'm ready for any question or comment before I go. Hello? Are you there?
Yes. No, doctor.
Right. Okay.
Thank you, doctor.
Thank you. Right. I'll see you soon, inshallah.
إن شاء الله. Thank you.
Bye.
Thank you, doctor.
You're welcome.